Hi everyone, welcome back to my channel. I'm Dr. Cindy Wong, and today I want to pick up where I left off in my last video about my GI pathology fellowship experience. And let's get started. So let me break down what it is like for the GI pathology fellowship here at Stanford. It is a 1-year fellowship, and you do both medical liver and tubular GI, including gallbladder and pancreas. And so it's very comprehensive. And I have to say, when I first started fellowship here, I felt so incompetent because I honestly did not get a good liver training when I was a resident. So I knew like nil. Well, not nil. I knew something because I studied medical liver for the pathology boards, but I only knew like the basics to get me through the boards. I honestly don't know what to do with a real liver biopsy if it was handed to me. So when I started, it was a struggle bus for sure. That said, the attendings here were very understanding. They were totally okay with teaching me like they would teach a resident about liver, because at Stanford, the residents do medical liver. It was very nice, and I felt like I learned a lot really fast, and overall, I feel like now I'm okay with livers. I could do liver biopsies if I was forced to, but I still don't feel like that I'm like an expert at it at all. But that says I still have the rest of my fellowship to finish. All right, so the GI fellowship here is broken into the following services. There is the consult service, there is the frozen service, Hotseat service, there's the junior attending service, and then there is elective and research, of course. So service that I am on the most is the GI consult service. We not only see the GI consultation cases, so those generally are the tough cases I've mentioned before. We also get inside-outside cases where we call IOs, which are patients who are diagnosed elsewhere and now they're coming to Stanford for their surgery or for their like clinical care, and the clinicians here wants to review their pathology. Yeah, so the consult service is in the morning medical livers, and oh my gosh, there's actually a lot of liver biopsies performed here. So not only do we look in-house liver biopsies, we also look at, inside-outside liver biopsies. We also look at consultation liver biopsies, and those are tough. And then that happens in the morning. In the afternoon, we do the GI sign out, which does the IOs and the consult GI stuff, and that's also most of the time quite challenging. The IO sometimes could be easy or they could be hard. It could be a simple case of here is a gastric biopsy and there's cancer there and they're coming here for their gastrectomy. So all we do is like, thank you for giving us this. We agree with the outside pathologist, there's gastric cancer here. And then that's the report. But sometimes even these inside-outside cases can be really tough because technically these are like a comprehensive review of patient's pathology. If a very complicated patient comes, their inside-outside case can be multiple outside pathology specimens. I've gotten cases where the specimens dated from 2021 all the way back to like 2009, and it's like 5 or 6 cases, and it comes to us in multiple stacks, but that's just one case for us. And I talked extensively about consults last time. So that's our day on the GI service. Like I said, we don't gross, so we spend most of our day just previewing, signing out, and writing. I have to say, when I first started, because I came from a different institution, I had to learn like everything, the software, how people like to write the reports all over again. So when I first came, it was so hard for me because I'm like writing reports how I'm used to writing in Chicago, and now come here I have to like learn new preferences. Attendings like writing things differently, and learning how to use PowerPath, whereas I had used CoPath before. Now I know how to order IHCs. Now I know where to like pick up stuff and like where things are. I feel like I've definitely cut out like a whole hour or two of my time compared to when I first started. And also because I'm just getting better at writing these reports. And then our other really busy service that we do as fellows is the Hotseat service. And this is definitely something that not a lot of programs still do. What I mean by Hotseat is you get first look at all the slides that come out in-house. Instead of all the slides going straight to the resident for previewing, all the slides goes to you. You preview the slides, and as the fellow, you have to make quick decisions. Do I think this case needs more workup? Does it need more IHCs? Does it need more levels? Does more need to be submitted from the gross room? And you make those decisions. You order the IHCs, you tell the gross room to submit more levels, and then you pass off the case to the resident, and the resident will then preview the case, sign out with attending. The resident will come back to you with, this is what me and the attending decided on these cases, and they'll discuss with you. It's great education. Like for me, I feel like doing this, I get to see the rest of in-house, so I don't lose my skills in diagnosing everything, gyne, soft tissue, peds, GU, and breast. Oh God, breast. But this was very important to me actually when I was looking for a fellowship, because at the time I swear to God I was gonna do private practice setting, so I know I would be sending it out general. So I needed to go to a fellowship where I could still practice my general search path skills, and I thought Hotseat was a great way of doing it, and it really is. Hotseat days are Monday through Saturday, whole days. So that's the one service in which you're forced to come in on a Saturday to work, and anything else, all other services, you don't have to come on the weekends. The weekends are off. The next big one fellows do is junior attending, and this is a rotation where you literally what the name is. You're the junior attending. The resident comes to you after they've previewed, and you sit with the resident and sign out, and then you work that case like this is your case. You order whatever things you want, you do whatever you need with this, show other consultants or whatever you want, and then once you finalize that report, you need to make sure everything you think needs to be said in this report is said in this report, and then you send off to the attending, and then the attending will be like, yay, nay, here are some changes. So it's a very good rotation, because especially if you're gonna be staying in an academic center, it is good practice to know how you will interact with a resident, and it's good practice for you to teach residents. And I feel like it looks great on your resume if you're looking for a job, especially in an academic setting, saying like, I've done this and I really enjoy working with residents, and this is how I feel like my teaching method with residents are, and so on and so forth. So it's a very challenging one because you're being the attending, but at the same time, you also have that safety net where if you're totally stuck, you write this report, you send to attending, they're like, yeah, well, let's change it. Let's do this instead. And they'll be like, let's order these things instead. And it's still a learning experience for you as well. So that's junior attending. The next set of rotations that you have is a grand total of 4 weeks of Frozens. And when you're on Frozens, you are kind of like junior attending of the Frozens. The idea is you work with the residents, see how the resident does it, to give them help if they need to, tell them how to section things if they need to, and then the resident will make the sections, they'll make the slides, they'll make the stained slides, and then they'll give it to you. And the idea is you're gonna look at it, and then you're gonna come up with a diagnosis to tell the attending, and then they'll be like, yay, nay, and you'll call the OR and say, this is the Frozen diagnosis. It's really good, especially if you're going to academic center, because there are fellowships out there who the fellows don't look at Frozens at all. And when you go to academic center, there's for sure going to be Frozens, and Frozens is not subspecialized sign out. There are places that do subspecialized Frozen sign out, but most of the time Frozens are general. So it's a good way to still experience that Frozen experience. And this is another place where when I was saying how grossing is so important, because there's times where they literally send a whole breast and be like, I want you to freeze the lesion and tell me the lesion's there, or they'll give you this whole larynx and be like, can you freeze me, blah blah blah. And then you need to know how to properly gross these things, so that just by taking a Frozen section, you're not ruining the case for when it's finally grossed. So yeah, this is especially if you're staying in academics, a very good reason to be very good at grossing. Finally is the elective and 1 month of research. Honestly, Stanford is very supportive. Whatever kind of research you're interested, there's a lot of attendings, a lot of research projects. I guess the one downside I have to say, so not in terms of the research elective, I'm talking about the downside of coming to a new institution for 1 year fellowship, whereas doing fellowship in your home institution. And when I came here as a brand new fellow, I felt too stressed initially because I needed to learn the whole system to take on a project. And by the time I did find a project, it was too late for me to submit for USCAP. Unfortunately, USCAP submission for their abstract is in September. And so basically, unless you start a project with someone right away when you first start fellowship, there's no way you'll meet that deadline. It's okay. I now have several projects on my belt to do. But it's okay. I just didn't get to go to USCAP this year. That's all. And then you also get 4 weeks of elective time. So this is where you can pick different subspecialties of search path to do. So for example, I did derm for one of my elective because I thought I was going to private, and private, they will do general sign out, and a lot of private places end up doing their own derm. And I felt like I have very little derm. Like if it's not an SCC or basal cell or like a melanoma, I have no idea what I'm talking about. So that's why I was like, I need to do a derm rotation to learn about the non-cancer derm. You could pick a rotation to do any subspecialty. And Stanford, I think they basically have all subspecialty of surgical pathology. So it is a good time for you to pick up new skills to help you be better at, be good at your job when you graduate. And then the last thing I want to talk about is the requirement for AP call. AP call is a grand total of 20 days in the whole year. You're in charge of the AP call pager, and then you're also in charge of frozens overnight. So the call is, like I said, 20 days in total, and you do it in 2 to 3 day time blocks, which average out to be about like one time block a month. It's not that bad. I've done more than half of my AP call so far, and it's not like every day you're on call, you get something. I've only had to go into the hospital maybe like 3 times in all the times I've been on call. And so it's like, it's not as crazy. Oh my God. I remember during residency when I was taking, combined AP-CP call, that was horrible. This is so much better because you're only having to deal with the AP side of things. All right. I think that's it for this. I think that's a pretty good generalization about everything that I've done in fellowship thus far. And I'll probably make a video later once I've finished fellowship to give a grand conclusion about my experiences. But overall, like I said in my first video, I really enjoyed it here. Okay, I hope this was helpful to some of you who will be applying for GI fellowships here at Stanford in the future. And I will see everyone next time. Bye!